So anyway, I just want to say, guys, thanks. This was a really great conversation, and we covered a lot. We've done a lot of work here. Just to close, I want to get final thoughts from everybody. If you have anything to say, Sarah, we'll start with you.
Oh, not fair.
I'll start with you. You get the first thought.
Well, I think this is an incredibly exciting time to be practicing. All these things that we've discussed in HER2 positive and ER positive breast cancer, and we have so many more options for patients today than we did a decade or even 5 years ago. So the hope is for more targeted and less toxic therapeutics. But I think what we sort of ended with was the depressing part of our field, which is triple negative, and we have to really do better there.
Good. Edith?
There's a lot that has been accomplished and much more to be done, all in global collaboration, so that we can understand the biological differences of tumors and the environment in different countries, as well as looking at the healthcare delivery in the United States and other parts of the world, so that we can utilize this data from clinical trials and try to apply the data to as many patients as possible so that they can benefit. Last but not least important is that we also have to think about our patients as the number one reason for all of us doing this, having these discussions amongst colleagues, developing clinical trials, and thinking about the translation of the basic science data into the patients' lives. I think the patients are depending on us to continue our work.
Hope?
I think in the last year we've seen for the first time the ability to improve outcome for patients with metastatic ER-positive breast cancer. And although triple-negative disease patients have the shortest survival, the largest population we see have ER-positive disease still in the metastatic setting. And now we have even new drugs that are exciting in phase 2, lots of drugs that are in randomized trials impacting the PI3 kinase pathway. So I think that's really exciting, and the movement of these drugs into the early stage setting, trying to better understand the subtypes of ER-positive disease where they work, is really exciting as well. And also, I think what's been exciting in the last few years is the rise of neoadjuvant therapy as a way to treat patients with early stage breast cancer. I mean, treating in the dark is always very unsettling. So even though we don't yet know how we can improve patients with a bad outcome, it may be that that's where we can best understand the ability to treat more resistant disease. And that's an arguable area, but it could be that, if you give the treatment up front that's right, that's where you get the best outcome. And of course, HER2 is an exciting area.
Andy?
I'm glad you did ladies first.
I haven't finished with Joyce.
Joyce, no.
Well, let's finish Joyce.
Joyce,
let's
Joyce,
do Joyce. Then we'll do Andy.
Well, I guess I'll just reflect that just having been at ASCO here a day and having been at some meetings so far, listening to various development plans, I've been struck by how the competition in the pharmaceutical industry right now is really going to play for our patients' benefits. We're seeing things like triplets being developed, and going from phase 1 to phase 3. Wow, I would not have thought that was possible, 5 years ago. The pace is changing because there's a lot of competition. So our patients are going to be the beneficiaries of that.
Yeah, Andy?
Yeah, I think we're really, with apologies to Malcolm Gladwell, at a tipping point, but in a very good way. We're at a tipping point because we really have unraveled the biology of all the intrinsic subtypes to a level that thus far hasn't been achieved. And we're able to develop rational targeted therapeutics to hit critical pathway components. And it becomes clearer and clearer that we're going to have to combine many of these pathway inhibitors in combination to avoid feedback loops that are going to overcome our therapeutic efficacy. Underlying all of this, and the tipping point for me, as you alluded to, Joyce, is cost. And it's going to take a village of agents, and it's going to take a great amount of resolve to make the biological breakthroughs available for our patients, and hopefully that will happen.
Well, this has all been great, and I just want to say as the last point, we really are at the tipping point. I think that as we're really at the beginning of the genomic era of understanding, at least hopefully, the spectrum of DNA lesions in the tumors. But with that comes incredible complexity, and I think that the complexity, we're really going to have to think about how to design clinical trials. And if you think about our sarcoma colleagues, where every tumor is very rare, and it's very difficult to do a huge clinical trial of 1,000 people, it may be the same thing. We may only have 50 or 20 or 30 people with that particular spectrum of mutations that you want to use that triplet in. And so how do we expand that? How do we generalize that knowledge to other people? I think we're really going to have to think very hard about how we do trials going forward. I'll end with that. But again, thank you all very much for listening to us, and have a good night.